I'm a senior investigator in the Center for Cancer Research in the National Cancer Institute. I'm a board certified and fellowship trained otolaryngologist from a clinical standpoint. Had a Hopkins practice for several years before I came on full time to the NIH. And so my clinical practice and my research program is all now here based out of the intramural research program of the National Cancer Institute. And my research program studies both HPV positive and HPV negative head and neck squamous cell carcinoma, as well as for the past 5 or 6 years, a program dedicated to recurrent respiratory papillomatosis.
So I'm an associate research physician within the Center for Immuno-Oncology, which is part of the Center for Cancer Research here at the NCI. I am a board certified in internal medicine and in medical oncology. I did my medical oncology fellowship here at the National Cancer Institute, and I spent a lot of time focusing my clinical and translational research in metastatic or advanced HPV-associated cancer. So I have the specific interest in common epithelial cancers, but with Dr. Allen, collaborated on developing novel therapies for another HPV-associated condition, which is recurrent respiratory papillomatosis. Recurrent respiratory papillomatosis is characterized by chronic infection with HPV 6 or 11. This chronic infection leads to the development of these benign tumors or papillomatous growths that occur throughout the aerodigestive tract. So specifically, when it causes problems for patients is when these growths grow in the larynx or the voice box, and also down in the windpipe or the trachea, and even in some patients into the lungs. You can imagine with these growths occurring in these locations, they can affect a person's ability to speak. They can affect their ability to breathe. And if they're down in the lower portions of their lung, it can actually block the lung and cause infections and so forth. So they cause a lot of disruption in patients' lives. This is, as I mentioned, a chronic disease. And the only treatment up until earlier the past month was a resection of the actual papillomatous growth, try to improve a patient's ability to speak and to breathe. And so this is a chronic disease, and patients require tens to even hundreds of these kind of interventions in order to palliate some of these symptoms.
So, for reasons that we don't understand, a small subset of patients will develop these chronic viral infections. Most people are exposed to these HPVs, but a subset of individuals will not have immune clearance after an acute infection. And the chronic infection leads to changes in the cells that make up the lining of the throat and voice box that result in the growth of these papillomas. It is poorly understood and of great interest to the RRP research community to understand how these HPV infected cells are evading the immune system, because most of the time the immune system is very facile and very good at detecting viral infection and eliminating those infected cells. As Dr. Norberg mentioned, the growth of these papillomas is recurrent because the standard of care surgery up until this point, which has been procedural, either ablation of the papillomas with a laser or resection of the papillomas in the operating room, doesn't really address the underlying cause of the disorder, which is this chronic HPV infection. It simply palliates the symptoms and tries to give the patient an open airway so they can breathe, and removes papillomas off the vocal cords to maintain their voice. So we and many other investigators have been searching for a long time for a way to treat these that is more in line with the understanding of the actual pathophysiology. In other words, treatments that truly address the underlying cause of the disorder, which is the chronic viral infection. The generic drug name is Zopapogene Imadenovec, and then the trade name is Papzimios. So Papzimios is an adenovector-based immunotherapy. The adenovector harbors a payload that encodes portions of HPV-6 and HPV-11 that we know can be recognized by the immune system. And by administering Papzimios with a shot subcutaneously under the skin. Papillomaviruses then enter cells of the immune system that express the HPV genes, and this expression of the HPV genes through a system of cellular interactions in the immune system results in the training and expansion of T cells against HPV. And this is the key. We know that the only cells of the immune system that can recognize and eliminate cells already infected with a virus such as HPV are T cells. So the underlying principle of the treatment is to peripherally administer under the skin shots of papillomaviruses that over a series of 4 injections result in the priming and expansion of an HPV specific T cell response. These T cells are in circulation in your periphery, and they then traffic into the papilloma where they recognize cells infected with virus and kill those cells.
So we conducted a phase 1/2 clinical trial, adjuvant papillomaviruses in adult patients with RRP. The way this study was designed initially was to look at safety of 2 different dose levels of papillomaviruses. All patients were greater than 18 years of age, and they had to require at least 3 interventions in the year prior to starting the treatment. And they received, as Dr. Allen mentioned, 4 administrations of papillomaviruses. Prior to the first administration of papillomaviruses, they had a standard of care cleanout, which again indicates that we gave this in the adjuvant setting. Over the 12-week treatment course, there was also the ability for the disease to be kept at a minimal residual disease state, where we would clean out any residual papillomavirus disease at days 43 and days 85, with the overall goal of trying to keep the disease burden as the smallest as possible. The reason for that is that we know that papilloma in itself can suppress the immune cells from clearing the virus. If we're then able to eliminate the papilloma, we can then decrease the immune suppressive features of the papilloma. After the one-time treatment, patients were then monitored for 1 year to see if they required any clinical interventions. And those interventions could be an in-office procedure, or they could have meant an OR procedure to palliate the symptoms of RRP. So in the phase 1 portion of the study, we treated 15 patients. We found that the highest tested dose was tolerated, and that was then used to treat additional patients. For the safety profile, it was highly favorable, in that most patients experienced grade 1 adverse side effects, including injection site reaction, fevers, chills, fatigue. They tended to be self-limiting, a couple of days at most. Some patients required analgesics, such as Tylenol or ibuprofen, though most patients it was self-resolving. The study was then expanded to treat an additional 23 patients, so that in total, we were able to look at 35 patients treated at what we call the recommended phase 2 dose. And this was really going to let us know whether or not the treatment was providing clinical benefits. So in those 35 patients treated, what we found is that 51% of those patients did not require a single intervention in the 1 year following treatment. The primary objective, as I mentioned, was the complete response rate. And the way that we measured the complete response was comparing the 1 year prior to treatment to the 1 year after treatment for an individual patient. We felt this to be the best measure of clinical benefit because within a single patient, there's a relative homogeneity in the requirement for the interventions for that patient to go about their life and control the disease. On the other hand, there's actually a lot of variability between patients and the disease. So in order for us to measure whether or not this therapy worked, we wanted to see within an individual patient whether or not the number of interventions that they were requiring changed at all. So as I mentioned, the complete response rate was 51%. We found that 86% of patients treated had some reduction in the number of interventions that were required after treatment. Even though not all patients received an objective complete response, most patients had a decrease in the number of interventions that they required. In addition, of the patients that have had ongoing complete responses, there were some patients that had no presence of disease almost close to 3 years following treatment. So what we're thinking is that the patients that have responded, the responses are durable.
When a patient with RRP, whether it's newly diagnosed as whether it's been an existing long-time diagnosis, when they go to visit their otolaryngologist or their head and neck surgeon, until now, there has been no other option for that patient other than to receive a procedure, either a laser ablation of their papilloma in the office under local anesthesia or a resection of the papilloma under general anesthesia in the operating room when they need it, when they have symptoms that necessitate treatment of their papilloma. Other adjuvant treatments have been used off-label, but are relatively inconsistent in their clinical benefit and are not widely used. With FDA approval of Papzimios, there is now an option that will be widely available that patients and their otolaryngologists can consider. If you ask patients what they want, of course they would say they want to be cured of their disease. They want their viral infection to go away, and they want no more papilloma. What they would also like is to not have procedures. If their papilloma growth could be kept at bay to the degree that they didn't need procedures to palliate their symptoms and be able to go to work and be able to order a hamburger in the drive-thru and talk on the telephone and go on a walk without being short of breath, that's what they would desire. And Papzimios is the first treatment that offers this possibility durably for patients. It's the first treatment for RRP that attempts to address the underlying cause of the disease.
The one thing I can add to what Dr. Allen just said, prior to August 14th of this year, the only treatment were interventions either in the office or in the OR. Each of those interventions led to the chance of permanent damage to either the larynx or the trachea. That could lead to permanent vocal dysfunction and the requirement for a tracheostomy so that the airway can be protected, meaning that the current treatments could cause permanent harm to these patients. And so Papzimios, as Dr. Allen had alluded to, this is the first time that a treatment could offer a benefit without having the side effect of leading to potentially permanent vocal dysfunction or permanent airway dysfunction and not being able to breathe. So this is really a paradigm shift in how we're looking to treat RRP and providing medical therapies to really what is a medical condition compared to using surgery to treat a medical condition.